They call it the F-bomb method because people can't believe that their pain goes away immediately on different parts of their body. So it's really cool. A lot of people say it's a shot in the arm in their career. He had been to 3 surgeons for his back, hip, and leg pain. He'd been to 3 surgeons, and he had 3 different opinions. One wanted to cut his piriformis, the other one wanted to cut his back. They say it takes 18 years in the medical field for a breakthrough in medicine to hit mainstream medicine. I don't think we can wait that long, but my clinic is full of these people with these stories of had surgery, failed, spinal cord stimulators put in their back. So I say that we're not only saving these people from chronic pain, we're saving these people from the medical system. Or, like I say this all the time, a lot of my patients have gone to the most prestigious hospitals in the United States, in the world, and they get prescribed psychiatric medication for SI joint. Yo, everybody, what's up? Physical therapist, Dr. Ryan Whelton, coming to you from just outside the very hot, humid Tampa Bay area. If you're new to following me, I'm a physical therapist. I got a clinic where, like most people, have failed everything type story. And I figured out how to get exceptional results within that patient population. I developed methods. I published papers in peer-reviewed journals with protocols, proving what I'm saying is true with, patient data. They've been used for the better part of a decade now all over the world, and people are getting great results with them, they report, so that makes me happy. And I have all kinds of courses. Besides my journal articles, I have all kinds of courses. I have my rehab results course, which is my orthopedic protocols, which is what I do in here to get the results that I get. And then I have my sciatica cervical radiculopathy immediate results course. That works for me usually around 80% of the time, wiping it out, sciatica cervical radiculopathy. And then I have my myofascial courses, which people love. My myofascial course, I mapped 1,000 pages of maps of the body at different points that connect all over the body that exist at certain joint angles and angles of pressure. Let's say you have, pain here, you stimulate here, it connects here. But if you go like that, now it connects over here. If you go like that, it connects over here. If you go like that, just 5 degrees, now it connects down here. That, it connects up in the AC joint. Or if you move your finger this way, it connects over here. If you go that way, it connects over here. It sounds complicated. It's not complicated because I mapped it at certain joint angles and angles of pressure. So I just tell you, position the patient at, this joint angle of pressure. And, it's like a reflexive pain point. So you have pain and it's like the reflex that you stimulate. I published a paper on it, and a lot of the people that do the method love it. They call it the F-bomb method because people can't believe that their pain goes away immediately on different parts of their body. So it's really cool. A lot of people say it's a shot in the arm in their career. It's just fun to do. And it's usually, in my patients, usually a pretty dramatic increase in range of motion. I posted a comment that someone wrote that said that, I believe it was like, they've used it on 33 patients or something, and it worked 32 times, like just on their shoulder, full range of motion, no pain type thing. And I have that intro shoulder course is money back guarantee. So it's really, 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 really cool. And then I have my inner circle. So if you want to become a VIP member, I'm teaching live coming up, and I'll announce it, but I'm teaching live and I'm doing it on Zoom, where I'm going to teach diagnostics. I'm going to teach these outside the box methods I come up with. And my goal is to get people diagnostically on point. And here's what to do. Here's how I get, my patients better, copy, paste it type thing. So I'll announce that, but it's really cool. And then I have my business course, which I teach people how to open and run a business, a results-based, cash-based business like I have. So today I am talking about a patient I had the other day. Now, so the patient was a surgeon, okay? So he's a surgeon, and he comes up here from like an hour away, and They wanted to cut his piriformis muscle. Okay? I've seen this before, like 3 times in my career, where the surgeon wants to cut the piriformis muscle. And each of the 3 times that I've seen this, it was so basic what was causing it that it was like, whoa, man, you know? So he had been to 3 surgeons for his back, hip, and leg pain. He'd been to 3 surgeons, and he had 3 different opinions. One wanted to cut his piriformis, the other one wanted to cut his back and do a discectomy or microdiscectomy or something. And I forget what the other guy wanted to do. And so he had back pain, hip pain, and then what he called L4 dermatome pain, like the thigh, right? So in my head, like you just described, a referred pain pattern of the SI joint. No one should be getting cut unless it's an emergency, unless you screen the SI joint. It's mechanical, just screen it, you know? Because this clinic that I have, it's a tragedy what happens to these people in the medical system. They get full. I got 3 patients right now that have had their spines fused that they're no better after it, and the surgeon said it was a surgical success. And then I open up their SI joints, I rotate their sacrum back, and boom, pain is gone. Okay, and instantly confirming that it was this. I published this. It is on my website, wheltonmethods.com. And I published my SI paper and my sacral paper. I streamlined that evaluation process and showed you what I believe is causing it. And I've been teaching this I published it in 2020. So 5 years later, it's now taken on a life of its own. The journal told me a year and a half into it, it was one of the top 2 most read papers in the history of the journal. But I'm assuming now it's got to be number 1. So 5 years later, because it's actually ranked on Google. It's right up there because people are searching for it, which is really cool. So it makes me happy. Okay, so this patient came in. He was a surgeon. He had back pain, hip pain, right hip pain, and what he called L4 dermatonal pattern pain, right? In my head, I'm like, we need to screen your SI joint. Well, he starts talking. And they want to cut into 3 surgeons. One, I forget what he said, but the second one wanted to cut his back, disc, microdiscectomy or discectomy, something like that. And the third one wanted to cut off his piriformis muscle because he had hip pain. And I was like, whoa. So let's just screen for this first, right? So I had the person, his pain was on the right side, okay? So I palpate the PSIS right here, okay? You just put your thumbs on the knobs and it kind of flops over the PSIS. I asked him to extend back, and my right thumb translated superiorly on his PSIS, and my left thumb translated inferiorly. So that told me on the right side, at the very least, he had what's called an upslip. So the reason why it went up, translated superiorly, is because if it's in alignment, it drops back with the sacrum. But if it's up like this, it starts to go like that. Okay, so I pulled on his leg, brought that back down into alignment, okay? And then he had a negative prone press-up test. I do it in standing, but negative prone press-up test, meaning both of my thumbs translated inferiorly. And then you always have to get the upslip first. Read my paper. You always have to get the upslip first. And then what I did is I laid him on his side, and I pushed medial on his ASIS, gapping open the out flare of his pelvis, okay? So I gapped open the out flare of his pelvis. And when I did that, he stood up and he felt better. It was out of his leg, still in his hip. And then I put a ball between his knees and I had him squeeze. Why? Because the adductors attach to the pubic symphysis, and when you squeeze, it goes like that if you get the upslip first. You got to get the upslip first, okay? And when you go like that, then I asked him, I said, is the pain still in your hip? And he said no. They were going to cut his piriformis off. And it was actually not his piriformis. It was SI joint, referring pain into his hip, okay? That surgery would have failed, and he would have had his anatomy permanently altered. So he also had a sacral rotation. Okay, so when I asked him to do, you can do a prone, if you read my sacral paper, I streamlined that evaluation process. It was too complex. And I had him bend forward. Some people say they can't see it in standing and they need to do a prone press up test, which whatever it takes, do it for you to see it. But if you're going to do a prone press up test and press up, a lot of times they fire their glute and throws off your test. So if you read my paper, I had him bend forward, and as he did, my left thumb translated towards anteriorly towards his belly button. And that told me that he had a sacral torsion, right? And then you just lay the person on the back on their back to check your assessment. And what you will see is that almost always the left, I find, piriformis muscle in a 90-90 test was a 5 out of 5 strength, and the right was like 3+, 4- out of 5, which is pretty typical. And the reason why that happened, and your left thumb translated anteriorly, is because the left side was too strong compared to the right, and it rotated. Okay, so I rotated that back, had him squeeze the ball, boom, all of his pain was gone. His L4 that they wanted to cut his back open for the disc was gone. His hip pain, which they wanted to cut his piriformis off, was gone, and his back pain was gone. Okay, so I sat there and I explained to him. I said, "You've been misdiagnosed." And now this is a surgeon, orthopedic surgeon, and I said, "You've been misdiagnosed, and this is a mechanical issue. I don't doubt you have a herniated disc. If they wanted to cut your back open, then they have to be able to justify that to an insurance company, but this isn't where the pain is coming from. It's actually coming from your sacroiliac joint." So it was, it's the more you do this, and I know my colleagues are doing my methods all around the world, and they're putting comments up like, "Yeah, no, I'm seeing it too." Like the amount of failed surgeries and amount of craziness that goes on when it's the SI joint, sacral torsion, sacral shear. That's what the trifecta. It's this mechanical back pain nightmare that people find themselves in, and they just, they go to the doctor and they go in, without ever screening their SI joint. So this has been out for 5 years. They say it takes 18 years in the medical field for a breakthrough in medicine to hit mainstream medicine. I don't think we can wait that long, but my clinic is full of these people with these stories of had surgery, failed, spinal cord stimulators put in their back, ablations. It is totally bonkers what I see. And they're all trying to figure out where the pain's coming from. But all they have to do is open up their sacroiliac joint. Now, okay, so let me talk about the other 2 times I've seen someone wanting to cut someone's piriformis off. So the person took their hand and they said along the border of their lateral border of their sacrum, they have pain. So they got pain on the lateral border of their sacrum. So they go to the surgeon and they want to cut their piriformis off. I saw one lady they actually removed their sacrum, removed the person's sacrum. And they wanted to cut the piriformis off because they thought that would relieve the pain. But anybody that follows me knows the reason why I say that I am an inventor, and the reason why I have made discoveries is because I'm a root cause thinker. When I find something, I want to know what's the why behind it. Yeah, but okay, well, great. Well, what's the why behind that? What's the why behind that? What's the why behind that? Until I get to the root cause, okay? So my question is, why would someone's piriformis on the lateral border, the lateral border of their sacrum be irritated? And years ago, I noticed that people with sacral torsions would go like this. They would take the blade of their hand and they would just go right up and down the lateral side of their sacrum, and they would say that they have pain in their sacrum here. But then I noticed that when I assessed their sacrum, read my paper on sacral dysfunctions, I streamlined it, I made it easy. You don't have to know all these different axes it moves on. That's way too complex to diagnose. All you got to know is where the ILAs are for sacral torsion. And I had them bend forward, and when he did, the left thumb dipped in, and I started to notice when I would rotate their sacrum back into alignment, instantly the irritation that they had, the pain that they had, that the lateral aspect of their sacrum was gone. Why would that happen? The reason why that happens is because that's where it attaches. So if I took your arm and I pulled it, it would irritate it, right? That would irritate the muscles, right? But that's what's happening here to these people, is that they're developing it. They developed a sacral torsion from a piriformis imbalance. Okay, so their left piriformis, it's just strange, but what I've found is that when people have confirmed it all over the world, what I've found is that it's almost always the left piriformis is like 5 out of 5 strength, and the right one is 3 plus 4 minus out of 5, something like that. And it was shocking to me that it makes it easy to teach, but you just test their strength. If you're not sure which way the sacrum's rotated, put them in a 90-90. Piriformis, hold their leg up in a 90-90 and test, say hold. And you can break the right one. I did it 3 times today to people. I showed them. They were shocked. So what you do is read my paper or my rehab results protocols and have them do the piriformis strengthening exercise only on the right side is what I have my patients do. And that usually takes 5 weeks or so, and the piriformis will realign, and the sacrum will realign, and the strength will return into their piriformis muscle. So this orthopedic surgeon that I saw this past week did not need to have his piriformis cut. And those other 2 patients that I was telling you about did not need to have their piriformis cut. They just had a simple sacral torsion that was causing it. Root cause. We have a great symptom management model. You got pain, we'll cut it. You got pain, we'll inject it. You got pain, we'll massage it. You got pain, we'll adjust it. But why would that happen? You got to ask why. And when you start asking why, you start figuring out that the problem is actually not what you think it is. It's a different issue. I can't stand the term piriformis spasm. I literally can't stand it. That's like saying I got pain. Like nice diagnosis. Like the person has chronic pain. Like that's a diagnosis. Like yeah, but like why? And when you look at a piriformis spasm, it can come from nerve. I just had a patient in here with a nerve piriformis spasm. It was in her butt. It hurt from nerve, straight up nerve. I realigned her SI joints, and it was not SI joint or sacral dysfunction. But piriformis spasms so many times come from a rotated sacrum. Okay, you just rotate it back, and when you rotate it back, instantly my patient's pains go away, and it's just like, no, that was it, but they'll inject it, they will, massage it, drop elbows into it, and it's actually this, and it's super easy to assess in that root cause of sacral torsion, shear, anterior sacral tilt that I published, and it's on my website, wheltonmethods.com. And hopefully you are doing this, and hopefully you have people in your clinic that you are sharing my papers with and asking them to screen these people. Because I always say, if you ever saw what happened to these people after they leave a traditional physical therapy clinic and it fails because no one screened their SI joint in their sacrum, sacral torsion, shear, or anterior sacral tilt, then you wouldn't wish this on anybody, what happens to these people. They go into the medical system, and the next thing you know, they get this. I call it the story. They've tried physical therapists, chiropractic, injection, surgery, orthopedic surgeon, neurosurgeon, x-ray, MRI, massage, acupuncture, repeat, 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 repeat. I see it all day long. And these I can diagnose somebody without even touching them. If they've tried everything and they've had it for like 5-10 years, I'm like, okay, well, I pretty much know what this is. I just have to confirm it with my hands, and realign it, because that's their story. So when we fail and we fail to screen for SI joint sacral torsion shear, you just turn that person's life upside down. And it is a tragedy. It's a tragedy what happens to these people. So I say that we're not only saving these people from chronic pain, we're saving these people from the medical system. Or, like I say this all the time, a lot of my patients have gone to the most prestigious hospitals in the United States, in the world. and they get prescribed psychiatric medication for SI joint. They had us, they were told they didn't have anything wrong with them. They got antidepressants, anti-anxiety medication, and one person got Haldol, which is an antipsychotic. And I just realign their SI joints, rotate their sacrum back, boom, pain's gone. And it's like, and then we stabilize it, do the rehab, boom, pain's gone. And I'm like, no, crazy, literally crazy. So anybody from the lower thoracic into the foot. And by the way, the other day I had another person with ruled out by a medical doctor testicular pain that no one knew what to do about. And he's my patient right now. And I opened up his SI joint and the testicular pain was instantly gone. And he had ultrasounds on the genital area. Nobody could figure anything out. And I'm like, I think I know what this is. I always make sure that something like that, because that could be serious, is ruled out by a medical doctor, the testicular genital pain. And once it's ruled out by that, we open up their SI joints and the pain goes away. It was that. And I don't believe that's documented anywhere in medicine, that testicular pain can be SI joint pain. So I might actually email the journal I published my SI paper in and ask them to update that. That's what I've found over the years. I've probably seen it 7 times, testicular pain. I would say 6, 7, something like that nobody can figure out. And then open up the SI joint, boom, pain's gone. And then we do the rehab, boom, pain's gone. And it's like, wow, man, that's crazy. So it can cause all the neurological symptoms that can happen with a herniated disc, including weakness, including foot drop. Go to Whelton methods on YouTube and type in patient makes medical history ? I think I labeled it. And you can watch me open up someone's SI joint with foot drop and it comes right back. I've seen positive slump tests become negative slump tests by realigning SI joints. So that slump test can fool you. Anyways, that's that. Gotta save these people. Love you all. Peace.